Hello everyone, this is Dr. Jones from DrBeen.com. Today in the psychiatry series we're going to be discussing somatoform and related disorders. In this lecture we'll discuss the presentation and treatment approaches to such disorders. So let's look at the first case. Debra is a 44-year-old woman who has visited the doctor multiple times and none of them have been able to diagnose her condition. Today she presents with ankle pain, chest pain, back pain, headaches, blurred vision, bloating, chest tightness, tingling in her fingers, aching in her legs, and ear pain. Does anyone know what the diagnosis is? Well, this case illustrates somatic symptom disorder. Why? Well, it's a disorder where one or more somatic symptoms that are distressing result in problems in functioning. Well done if you got somatic symptom disorder, by the way. So in terms of risk factors for somatic symptom disorder, well, this disorder affects women more than men. It's usually inversely related to socioeconomic status. It usually begins by the age of 30. Data suggests that there may be a genetic linkage to somatic symptom disorder. Within families, male relatives tend to have antisocial personality disorder, whereas female relatives tend to have histrionic personality disorder. What typical symptoms may you see? Well, many physical symptoms affecting many organ systems, excessive thoughts, feelings, or behaviours related to the somatic symptoms, long, complicated medical histories, interpersonal and psychological problems may also be present, commonly associated with major depressive disorders, personality disorders, substance-related disorders, generalized anxiety disorders, and phobias. Patients will usually seek out treatment and have a significant impairment in their level of functioning. So how do we treat these individuals? Well, you must have a single identified physician as the primary caretaker. Patients should be seen during regularly brief monthly appointments. Should increase the patient's awareness of the possibility that the symptoms are psychological in nature. Individual psychotherapy is needed to help patients cope with their symptoms and develop other ways of expressing their feelings. The main key message overall I want to echo is safeguarding. These patients with somatic symptom disorder, they should only have one physician to see them on a regular basis, given the fact that in the future something physically wrong may actually happen to them and you need to be able to pick up on that. So let's look at another case. Jen is a 25-year-old female and she presents to the clinic unable to move her upper arms and her lower legs. A full workup is done, no abnormalities are seen. However, when further questioned, she reports an argument with physical violence involving her girlfriend that occurred this morning. And since this morning is when she hasn't been able to move her upper arms and lower legs. So does anyone know what diagnosis this is? Well, this case illustrates something called conversion disorder. Why? Well, it's a disorder in which the individual experiences one or more neurological symptoms that cannot be explained by any medical or neurological disorder. So basically, as a result of the fight with the girlfriend, she's kind of taken this experience and now she has neurological symptoms as a result. In terms of risk factors with epidemiology for conversion disorder, it's seen more frequently in young women, is seen more commonly amongst lower socioeconomic class, rural populations, low IQs, and military personnel. Commonly associated with passive-aggressive, dependent, antisocial, and histrionic personality disorder. Typical presenting symptoms may be the following: one or more neurological symptoms which affects voluntary or sensory functioning, must have psychological factors associated with the onset or exacerbation of the symptoms. Mutism, blindness, and paralysis are the most common symptoms. When it affects the sensory system, you may get anesthesia or paresthesia, so it basically means numbness or tingling. When it affects the motor system, you can get abnormal movements, gait disturbances, weakness, paralysis, tics, jerks. Patients may model their behaviour on someone who is important to them. So how do we treat these patients? Well, psychotherapy to establish a caring relationship with the treater has focusing on stress and coping skills can really help. Briefly monthly visits as well with partial physical examinations can help. So let's look at another case. Miley is an 18-year-old singer and she presents to the doctor convinced she has bladder cancer. She reports constant abdominal pain that doesn't go away. She has seen doctors numerous times and she's told there's nothing wrong with her. She doesn't believe them, but she thinks that you can help her because she knows 100% there's something wrong with her. Do you know what diagnosis this is? This case illustrates illness anxiety disorder. It's a disorder characterized by the patient's belief that he or she has some specific disease, despite constant reassurance that the patient's beliefs still remain the same. Symptoms must occur for greater than 6 months. In terms of risk factors or epidemiology of the illness anxiety disorder, men and women are affected equally. The most common onset is between the ages of 20 and 30. Typical presenting symptoms may be the following: preoccupation with disease. Preoccupation persists despite constant reassurance by physicians. The belief is not delusional. The preoccupation affects the individual's level of functioning. Duration is of at least 6 months. And how do we treat illness anxiety disorder? Well, psychotherapy to help relieve stress and help cope with the illness. Frequent, regularly scheduled visits to patient's medical doctor helps as well. So let's look at another case. Syed is a 23-year-old woman and she refuses to leave the house because she believes she's ugly and people will judge and laugh at her. She believes she is deformed and hideous. When you meet Syed, she is an attractive young female with no abnormalities of note. Do you know what the diagnosis is? Well, this case highlights and illustrates body dysmorphic disorder. It's a disorder characterized by the belief that some body part is abnormal, defective, or misshapen. In terms of risk factors and epidemiology of body dysmorphic disorder, it affects women more than men, typically ages 15 to 20, and other disorders that have been found include depressive disorders, anxiety disorders, and psychotic disorders. Typical symptoms may be the following. Most common concern involves like a facial flaw, constant mirror checking, attempting to hide the alleged deformity, housebound, avoids social situation, and causes impairment in their level of functioning. So how do we treat body dysmorphic disorder? Well, individual psychotherapy to help deal with stress of alleged imperfections as well as reality testing. Pharmacotherapy may include the use of selective serotonin reuptake inhibitor, tricyclic antidepressant, and monoxine inhibitor. Beware that this could be anorexia nervosa, so beware of that differential. So let's look at one of our last cases. A 3-year-old girl is hospitalized after her dad complains that the girl keeps having episodes where she can't breathe in the middle of the night. An apnea monitor shows numerous episodes of apnea when the girl is at home, but when she was in the hospital she had no episodes of apnea. However, shortly after the dad visits, the girl has numerous episodes recorded on her monitor. Does anyone know the diagnosis of this? This case illustrates factitious disorder. Why? Well, this is a disorder characterized by the conscious production of signs and symptoms of both medical and mental disorders. The main objective is to assume the sick role and eventually hospitalization. It's usually diagnosed with physical or psychological symptoms or both, and it consists of 2 main types: imposed on self and imposed on others. So in terms of risk factors and epidemiology of factitious disorder, it is seen more commonly in women and commonly in healthcare workers. As children, many of the patients suffer abuse that results in frequent hospitalization, thus the need to assume the sick role. Typical symptoms may be the following. Typically demand treatment when in the hospital. If test returns negative, they tend to accuse doctors and threaten litigation. They become angry if you confront them. So how do we treat these individuals? Well, it usually involves management rather than cure, and it can be quite difficult to actually diagnose factitious disorder. Along the same lines of factitious disorder, the next case is called malingering. So this is where an individual consciously produces signs and symptoms for an obvious gain. So money, avoidance of work, free bed and board, etc. It's not a mental disorder. So typical presenting symptoms could be the following. So you could have subjective symptoms, tend to complain a lot and exaggerate their effect on the effect of the symptoms on your functional lives. Preoccupation with preoccupation more with the reward than the alleviation of the symptoms. And how do we treat these individuals? Well, it's actually a difficult one, and I didn't really find a kind of consistent approach for any books. It says allow the patient to save face by not confronting the patient and by allowing the physician-patient relationship to work. Again, if you confront the patient, he's going to become angry and more guarded and suspicious. And again, it can be quite difficult to diagnose factitious disorder and malingering. That's a bit of a difficulty really with that one. So that's the end of the lecture. I hope you found the somatoform lecture interesting and I hope it was helpful. And if you have any questions, please let me know. Thank you very much.